Know that tuberculosis is a disease of great antiquity. So today's topic is provocative. What is new in TB diagnosis, treatment, and prevention? In the last 1 year or so, the world focus has been on COVID-19 and how to diagnose and to treat it. During this 1.5 years, there's been a sea change in tuberculosis. The first one is that up till now, there was the revised National Tuberculosis Control Program. This has now been modified to National TB Elimination Program. In the last 1 year, WHO has consolidated their guidance on how to prevent tuberculosis, both as far as guidance is concerned and operational handbook is concerned. They have also brought out consolidation of their guidelines on diagnosis of tuberculosis and how to operationalize the diagnosis. And finally, they have brought down consolidation of the treatment, especially of drug-resistant tuberculosis, and how to operationalize it. The module 2, which talks about screening, is still work in progress, and maybe that will also be added soon to complete the gap. All this started somewhere in 2015, when instead of controlling tuberculosis, people started talking about end TB strategy. And the end TB strategy had 3 pillars. One, the first pillar is integrated patient-centered TB care and prevention. Second pillar of this strategy is bold policies and supportive systems. And third strategy, the third pillar is intensified research and innovation. So that it is not only words, the vision is to have a world free of tuberculosis. The goal is to end global tuberculosis pandemic, and milestones from 2015 to 2000 lead this program. Strong coalition with civil society organization and communities would be forged so that you would have PPP, private-public partnerships. There would be protection and promotion of human rights, ethics, and equity, and adaptation of strategy and targets at country level with global collaboration. So we need to focus on India while keeping an eye on what is happening globally. The first pillar, which means integrated patient-centered TB care and prevention, needs to focus on early diagnosis of TB, including, this is for the first time they've enunciated that, universal drug susceptibility testing and systematic screening of contacts and high-risk groups. B, treatment of all people with TB, including drug-resistant tuberculosis, and patient support. So treatment would not only be drugs, but any support that the patient requires. Collaborative TB HIV activities and management of comorbidities. And the fourth part will be preventive treatment of persons at high risk and vaccination against TB. The second pillar, which means bold policies and supportive system, is political commitment with adequate resources for TB care and prevention. Towards this initiative, in September 2018, many heads of state met in United Nations and committed to provide their political support as well as adequate resources. Second part is engagement of communities, civil society organizations, and all public and private care providers. And this brings a lot of support and talent to the group that wants to eliminate tuberculosis. Universal health coverage policy and regulatory framework for case notification, vital registration, quality and rational use of medicines, and infection control. So that anybody, whether in private setup or in public setup, is treating tuberculosis, the central team will be notified through NTEP. Fourth part is social protection, poverty elevation, and action on other determinants of tuberculosis would simultaneously take place. And the third, which could be counted as another important pillar, is discovery, development, and rapid uptake of new tools, interventions and strategies, and research to optimize implementation and impact and promote innovations. So that they are not only empty words which sound good but do not convert into reality. Milestones for 2020, 2025, 2030, and 2035 have been set, and taking 1.3 million deaths in 2015, a reduction of 35% by 2020, by 75% by 2025, and thereon have been set. This would convert into prevalence of tuberculosis from 2015 baseline of 110 per 100,000 to 85 per 100,000 by 2020, 55 per 100,000 by 2025, 20 by 2030, and 10 by 2035. And of course, there should be no family having catastrophic costs that they cannot bear. And that would mean that financial support to everybody being treated for tuberculosis would also be provided. For each one of them, parameters have been set and are being continuously being monitored. So if we take a step back and look at what is planned, that if you want the current 110 cases per 100,000 to become less than 10 per 100,000 by 2035, the decrease has to be minus 17% every year. Unfortunately, before COVID came, the disease was at minus 1.5. And in some places, because the methods were improved, we were finding more cases than in the past. So overall, when they assessed, they found that if the target was 20%, only 9% were met. If the target was 35%, only 14% have been achieved. If the target was 0, only 49 of the families were not having catastrophic costs of treatment. If so, that means we are still far away from our targets, even interim targets. So what has been new is that there's been evidence accumulating that second-line drugs regimes containing injectable aminoglycosides, especially kanamycin and or capromycin, had higher treatment failure, higher relapse rate, higher mortality and morbidity. There was a new strategy tried, which was BPAL. The success of BPAL and its registration with US FDA indicated that it was possible to have all oral treatment for DR tuberculosis. DR would be drug-resistant tuberculosis. So to encourage all oral treatment, the definition or the classification of drugs used for second line for tuberculosis have been changed. Group A includes levofloxacin and moxifloxacin, bedaquiline and linezolid. These are all oral drugs which have excellent activity even against drug resistance. Or drug resistance have not evolved against them. The group B included clofazimine, which is normally used for leprosy, cycloserine, or its derivative as terazidone, and all of them are oral. Then in group C, we had ethambutol, delamanid, pyrazinamide, which are all oral, and then injectables like imipenem cilastatin, meropenem, amikacin, streptomycin, ethinomide, clothianide, and then PAS, which is also oral, but it is not as effective. So you would find that WHO indicates we should choose all three if possible to include either levoflox or moxiflox, bedaquiline and linezolid, and if possible include one or both of clofazimine and cycloserine. If there is resistance against any one of them, then we would take, then and only then would we take drugs from group C, and depending on whatever resistance is there. So that the change in process is that drug resistance testing would be done before you start this treatment. In every case, there are various resistant patterns which are possible. So instead of having a standard treatment, the suggestion was that now we should do universal drug sensitivity testing or universal drug resistance testing to individualize drug resistance tuberculosis treatment. Towards this endeavor, a number of changes have also been made in the diagnostic aspect. The diagnostics for diagnosis of of resistance, you have resistance against rifampicin can be done by CB, that is cartridge based. The X is which is already endorsed. Cartridge based Gene Xpert is already endorsed for rifampicin and INH. There's also another cartridge which will be known as XDR cartridge by CIFED, which has been developed to detect fluoroquinolone resistance and to detect aminoglycosides resistance. There's also in development end-to-end testing of rifampicin and INH, and that is also under process. LPA has already been, LPA is line probe assay 1 and 2, which line probe assay 1 will detect rifampicin and INH, and also talk about ethinomide and prothenomide. That is a line probe assay 1, and line probe assay 2, which will detect fluoroquinolone resistance as well as resistance against aminoglycosides, injectable aminoglycosides, that has already been endorsed. Targeted next generation sequencing, which will at one go detect all the genes which code for which are susceptible to anti-TB drugs at one go, or whole genome sequencing, that is under process, and sooner than later next generation sequencing would become the method of choice. Phenotypic drug resistance and microscopic drug resistance is also been looked at, and whenever we don't have molecular methods, then, and since molecular methods cannot differentiate between dead bacteria and living bacteria, liquid culture with drug resistance, that is the phenotypic drug resistance for all drugs, are also required to be done. Now, along with the difference in classification of the drugs which can be used for drug resistance tuberculosis, we have new definition of pre-XDR and XDR. XDR standing for extended drug resistance. So MDR remains the same. MDR would mean that there is resistance to rifampicin and INH, and then to that you would add pre-XDR if there is resistance to fluoroquinolones. Any fluoroquinolone, resistance to fluoroquinolone would make the drug, MDR drug, as pre-MDR. We have also come to realize that sometimes INH, there is monoresistance to INH, or there could be monoresistance to rifampicin. So monoresistance to INH, and RR would stand for when we have looked at only resistance to rifampicin. MDR will be when INH and rifampicin both are resistant. Pre-XDR would be when any fluoroquinolone, and the two fluoroquinolones used for treatment of tuberculosis are levofloxacin and moxifloxacin. And if it extends more than that, then the XDR, which early on used to be that there will be fluoroquinolones and injectable fluoroquinolones. Since the decision has been taken to discontinue injectable aminoglycosides in the initiation of any new treatment, the definition of XDR has been modified to include Mycobacterium tuberculosis strains that fulfill the definition of MDR or RRTB, and that also are resistant to any fluoroquinolones, and at least one additional group A drug. If it is resistant to fluoroquinolone, That means it becomes resistance to either levoflox or moxiflox and or levo and moxi both. Then the other two drugs that are available are delamidine and linezolid. And this has been grouped in such a way that more drugs, if and when they are discovered and they are effective, would fall into group A or group B, provided they are oral. In the rapid communication during these pandemic times, one of the key findings was that high diagnostic accuracy and improved patient outcomes were confirmed for Gene Xpert as initial test to diagnose pulmonary tuberculosis. So the recommendation is that we should replace smear microscopy with detection by Gene Xpert as replacement for smear microscopy as the initial test in all cases. The sensitivity in smear positive or smear negative with this strategy is 85%. The specificity is 98%. The sensitivity in HIV is also good, 81%, specificity remaining 98%. So the critical part is the rapidity with which we can diagnose resistance. And it is possible, since Gene Xpert takes only 2 hours to perform, it is possible that after 1 day itself of submission of the sample, we would know whether we are dealing with drug sensitive, rifampicin sensitive or rifampicin resistance infection. And overall sensitivity of rifampicin resistance was 96% with specificity of 98%. Subsequently, a new cartridge known as Gene Xpert Ultra, which is 8 times more sensitive than Gene Xpert and which has the lower detection level of 16 bacteria as against to 131 bacteria which Gene Xpert was detecting, has been made available, and it's been suggested, the interventions which have been suggested is that Gene Xpert Ultra as replacement for sputum smear microscopy using bacteriological culture as reference standard. And the results have been that high diagnostic accuracy of Gene Xpert Ultra in adults with pulmonary tuberculosis. Overall sensitivity is 90%, specificity is 98%. There have been some times when the trace result, which makes it very sensitive, are available, but the intervention suggested is that high overall sensitivity, 94%, and specificity of 99% when compared to phenotypic drug susceptibility testing. So Gene Xpert Ultra is as a replacement for smear microscopy as the initial test to be done for those suspected to be having tuberculosis. Another intervention has been in children. Gene Xpert Ultra as the initial diagnostic test for TB in children. And the sensitivity of this is 46% if the sample is, as we know, diagnosis of tuberculosis in children, especially the microbiological diagnosis of tuberculosis in children is usually very poor. And one of the reasons is that it's difficult to collect the relevant sample. Since the infection is in the lung and children have a habit of swallowing their sputum, normally we would do a gastric lavage, but for gastric lavage, the patient has to be admitted and when it's an invasive process and the yield in very good hands is good, but overall yield is poor. So instead of being so much in a hurry, ultimately whatever is swallowed would pass out in the sputum, in the stool. So with Gene Xpert Ultra, it has been suggested that instead of doing gastric lavage, we could always submit stool sample for detection of the presence of Mycobacterium tuberculosis DNA in the stool. And we have a differential sample processing method wherein we separate out the muck and float the mycobacterium if present in xylene, and then add xylene to the Gene Xpert Ultra and get positive results. So intervention is that in stool sample is an accepted sample along with nasopharyngeal and gastric lavage sample from children for making a diagnosis of tuberculosis in children. So we've dealt with pulmonary tuberculosis in adult, pulmonary tuberculosis in children, and now we come to extrapulmonary tuberculosis. And in extrapulmonary tuberculosis also, the sensitivity of Gene Xpert varies from specimen type, 50% for pleural fluid, up to 97% for synovial fluid. The specificity remains high. With the introduction of Gene Xpert Ultra as initial diagnostic test in adults with extrapulmonary tuberculosis, the sensitivity has improved, and it's been suggested that all cases of extrapulmonary where we are likely to get the bacteria, we should do Gene Xpert Ultra. There is TrueNet is an indigenously developed chip-based assay which has two steps, which involves first the isolation of the DNA and then detection of Mycobacterium tuberculosis and the detection of rifampicin resistance. This has also been found to be useful, that TrueNet assay is 83% sensitive and specificity is 99%. So TrueNet has been accepted as one of the methods which can replace sputum smear microscopy and should be adapted. I may mention here that both Gene Xpert and TrueNet, which were initially meant both for tuberculosis, were used in the last 1 year for COVID diagnosis with good results. So it is a chip instead of cartridge based. TrueNet is a chip based method. It has two steps. One will be extraction of the DNA, followed by then detection of the bacteria, and then if positive, for resistance. Recently, in another communication, they have evaluated Motrid complex automated nucleic acid amplification for TB diagnosis and found both Abbott real-time Mycobacterium tuberculosis as well as flu type MTB DR and fluoro type MTB Haynes test and Becton Dickinson's method good. They've also looked at Gene Xpert, which has an XDR cartridge, which should be available in the third or fourth quarter of the year. And they've also looked at a method for pyrazinamide. And now they will look at how to adapt it to the field situation. For the treatment, the key changes recommended are shorter, all-oral bedaquiline containing a regimen for eligible MDR rifampicin resistant TB patients. Replacing the injectable with bedaquiline resulted in significant better treatment success and a considerable reduction in loss to follow-up in MDR RRTB patients without previous exposure to second-line drugs and with confirmed fluoroquinolone susceptibility disease. The outcomes were similar irrespective of HIV status. The evidence assessment showed that in eligible MDR RRTB patients, a shorter all-oral bedaquiline containing regimen may be used instead of the standardized shorter regimen with an injectable drug. The BPAL regimen showed higher treatment success when used in patients in South Africa. Limitation of the study was that it had only 108 participants observed, and they were observed adverse effects including blood disorders, liver toxicities, peripheral and optic neuropathy, and this precludes programmatic implementation of the regimen worldwide until additional evidence has been generated. However, since BPAL regimen was successful in all XDR cases after 6 months, it has been recommended that BPAL regimen may be used under operational research conditions conforming to WHO standards. And the standards would be that it should be patient-centered care and support, proper patient inclusion, principles of good clinical practice, active drug monitoring and management and treatment monitoring, outcome evaluation, and comprehensive standard data collection. In patients where BPAL was used, it was bedaquiline 400 milligrams QID for 2 weeks, followed by 200 milligrams TDS for 24 weeks. Pretonamide was 200 milligrams QID for 26 weeks, and linezolid was 1200 milligrams once daily for 26 weeks. In such patients, the use of BPAL should be accompanied by individual consent, adequate counseling on potential benefits and harm, active monitoring and management of adverse effects. Patients should also be advised that reproductive toxicities have been observed in animal studies and that the potential effects on human male fertility have not yet been adequately evaluated at this point in time. So, summary of the key changes are that MDR RRTB patients with extensive TB disease, severe form of extrapulmonary tuberculosis, those with resistance to fluoroquinolone or who have been exposed to treatment with second-line drugs will benefit from an individualized, longer regimen designed using the WHO priority groups of medicines. For MDR RRTB patients without previous exposure to second-line treatment, including bedaquiline, without fluoroquinolone resistance, and no extensive TB disease or severe extrapulmonary tuberculosis, the preferred treatment option is a shorter, all-oral bedaquiline containing regimen. In this group of patients, national TB programs are advised to phase out the use of injectable containing shorter regimen. Access to rapid drug sensitivity testing, especially for ruling out fluoroquinolone resistance, is required before starting the shorter all-oral bedaquiline containing MDR regimen. BPAL this regimen may not be considered for programmatic use worldwide because unless additional evidence on efficacy and safety has been generated. However, in individual patients for whom designing of an effective regimen based on existing recommendations is not possible, BPAL regimen may be considered as the last resort under prevailing ethical standards. Decisions made according to patient preference, clinical judgment, also considering the results of susceptibility testing, patient treatment history, and severity and site of the disease. All treatment should be considered under WHO recommended standards as already enunciated. Finally, there's also been a rapid communication on forthcoming changes in the management of tuberculosis preventive treatment. It requires considerations at several key steps, identifying individuals at highest risk, testing them for infection, excluding active TB before starting preventive treatment, choosing the treatment option that is best suited to an individual, managing adverse drug reactions, supportive medication adherence, and monitoring performance. 1 month of daily rifampicin plus isoniazid, known as 1-HP, and the other regime is 4 monthly of daily rifamycin 4R are now proposed as TPP options for both high and low TB incidence setting, aligning the duration of certain regimen to the ones most often used and merging the 4 previous algorithm into one should be the aim of the program. This will be released now. This will be released as WHO consolidated TB guidelines and would be adapted by the program. So finally, if you ask me what are the changes that have occurred in TB management and diagnosis and prevention in the last 2 years, is that all oral treatment to replace injectables, universal DST before treatment in all DR cases under an algorithm, classification of second-line anti-TB drugs into class A, B, and C, definition, the new definition of pre-XDR and XDR tuberculosis, replace mere microscopy with Gene Xpert or TrueNet as the initial tests. Gene Xpert Ultra and TrueNet have been accepted. Detection and treatment of latent tuberculosis had been advocated. The name RNTCP has been changed to National Tuberculosis Elimination Program, and now we should have patient-centered approach to eliminate tuberculosis. Guidelines on programmatic management of drug-resistant tuberculosis in India was already proposed, and an algorithm is available